first topic that we're going to talk about is the Clinical Competency Committee. I get a lot of questions about how to use the Clinical Competency Committee and what is the Clinical Competency Committee and what is their purpose and what does ACGB say about them. So the bottom line is the Clinical Competency Committee serves as essentially your de facto academic standards committee. And so there's been a lot of discussion about, hey, do we need a large academic standards committee that if a resident's going to be dismissed from a training program, it has to go up in front of like 6 different program directors. You can understand how that's not necessarily fair for that resident, because how is a anesthesia program director going to really evaluate a pediatrics resident? And so this is when the academic standards committee or the clinical competency committee becomes very role. I would liken it to an academic standards committee for your program specifically. The whole purpose behind the clinical competency committee is to do a couple of things. Number one, it is to make sure that trainees are adequately progressing through their training program based on their PGY year. It is also a mechanism to identify residents that are in trouble early. So instead of waiting till they're a PGY 3 in a 3-year program and then finding out that they're having a problem and you don't want to graduate them, it's really there. It is incumbent upon that CCC to acknowledge and recognize when individuals are getting into trouble early. The other area that it becomes really important is they can be very, very useful in determining where you have holes in your program. And so do you have a hole in your rotations? Is there something like that's awful in your endocrine rotation because everybody's failing the endocrine portion of the IT exam or boards, etc.? Or do you need more resources in certain areas? So the CCC should work very, very closely with the program evaluation committee. The other piece that the CCC doesn't probably do well as a whole, I think, is we started getting really good about identifying those individuals that are in trouble. But every resident probably has an opportunity to do something better. Even your superstars, like how do you groom them to get where they want to be? Can the CCC provide information to those individuals to make sure that they're progressing the way they should be progressing so that they can meet their own career achievements? So this is, for the purpose of the CCC, there are a lot of different purposes. And so the purpose of the CCC for the program, I would argue, is to make sure that you demonstrate a shared mental model. And so what do I mean when I say shared mental model? Are we all working under the same understanding about what a PGY1 should be able to do versus what a PGY2, 3, 4, 5, 6, etc.? So you'll get your new faculty member sometimes that thinks that a PGY1 should be performing at a PGY4 level. Well, that's not really necessarily the way it works. And so you have to make sure that all of the faculty are having that shared mental model about this is what the expectation is of a PGY1, of a PGY2, PGY3, etc. You also want to make sure that it's standardized. And so, it's fine. I'm going to maybe talking on both sides of my mouth because I'm going to say, hey, it needs to be standardized, but hey, you need to individualize it for each particular resident. So there are standards, and I mean, if you look through all of the resources that are out there for CCZs and for programs, you can find milestones and subcompetencies that say, hey, by the time they're a PGY3 internal medicine resident, they should be able to interview a patient effectively and efficiently. They should be able to take the next step in the diagnostic algorithm. They should be able to coordinate care with the subspecialties. They should be able to do these things. That should be pretty consistent across the board with exceptions now and again. So for the program, we really want to make sure that we're demonstrating that shared faculty, that shared mental model, and we want to make sure that the criteria that are set are consistent across the program. For the program director, it is very important for the program director to have a good clinical competency committee. Why is that? Because the program director doesn't want to be the last man standing when that recommendation for dismissal or for suspension or for extended training. They do not want to be the last man standing and say, hey, I just made this decision unilaterally. This is great because I'm going to tell you it's going to become a problem. We know for a fact, just through legal issues, through board issues, etc., if we have a CCC that's really doing their due diligence as far as it's related to evaluating the residents and setting the standards and identifying problems early and helping rectify those problems early and giving them opportunities to cure, that CCC has done their job. It pretty much serves as the strongest light that you can stand on when you're finding yourself up in a court decision. For the faculty members, again, you're going to hear me say the same thing, shared mental model. So a lot of the same applicability for programs that has to do with your faculty as well. You want to make sure that they're sharing specific components of training that are alike across everybody. So you don't want there to be so much discrepancy between two faculty members that the residents left confused. For the program coordinators, your program coordinators spend a tremendous amount of time collecting this data. We just saw the information that Martha put up forward about the DOCC. Well, now they're going to take all that information and they're going to plug it into new innovations to make it easy for us to read. They're also going to take information from their semi-annual evaluations and their end of rotations and whatever other tools that you use to evaluate the residents. They take that, they synthesize it to make it something for the faculty that's easy to read and for the program directors that's easy to read. So this, for them, the CCC is a huge tool because it allows them to synthesize all that data into one place so that we're making accurate judgments about the training. For the residents and fellows, honestly, the CCC's goal is to improve quality feedback. I mentioned it earlier, I'll mention it again. We have a tendency to focus on the residents that are in trouble, and we have a tendency to ignore all the residents who are actually doing really, really well. Probably not the right answer. There should always be something that the CCC should have to offer of value for every resident in that training program. And the CCC's job, necessarily, not completely, but one of their jobs is to make sure that we extract that data so that we're growing every single training every single year. For institutions, I think that the CCC provides a lot of value because sometimes it's an institutional issue, right? Sometimes the institution's not providing resources for that program to actually be able to effectively train that resident. And it becomes a really big risk on the institution when a resident's being dismissed, or if the resident has a never event. We're going to talk about never events in Dr. Beeman's lecture, but you don't want to be the program that has a resident that actually had a never event. Institutions don't love it, the program doesn't love it, the resident doesn't love it either. And so the institutions actually really like the CCC because they are an early warning system. They identify issues with the training. They find out if the institution needs to be influxing more resources into that training program, or if there needs to be a completely different pathway for that program. So that's why the institutions should really value your CCC. The ACGME, I'll be honest with you, the ACGME really likes the CCC because they determine if that program is actually effectively training residents. Because if you find that your CCC is finding that every single resident needs to be fired or every single resident that needs to be promoted and there's not steps along the pathway, huge red flag for the ACGME. Programs are probably not doing what they should be. So structure, who should be on my clinical competency committee? Well, there's some really basic information here that you'll see that should be there. The program director, number one, they must appoint the CCC. At minimum, the CCC must be composed of 3 members of the program faculty, one of which must be a core faculty member. And then you can consider other members that are eligible for appointment. A couple things that I'm going to point out here. Number one, there should be absolutely no residents that sit on your clinical competency committee. None, 0. Unless you have a chief resident that's doing an additional year. So they've completely graduated from your program, they passed their licensing exam, they can come back as a chief resident to participate on your CCC. Otherwise, there can absolutely be no residents on your CCC. The other piece is, do you want to have individuals, when you look at that third comment over there, others eligible for appointment to the committee, include faculty programs, non-physician members, et cetera. Sometimes it's really good to have a nurse on there. Sometimes it's good to have a clinical pharmacist on there. But you have to prove to the ACGME, why is this individual playing this role? It's not I called my friend up from OU and I'm asking them to come participate because of whatever reason. They have to have a legitimate reason and legitimate interaction with that trainee in order to sit on the CCC. Program coordinators should be a part of the CCC. They should not be voting members. The other person that should not be a voting member of the CCC is the program director. I understand that some of the residency review committees may have a little bit of flexibility, but I'm telling you as a rule of thumb, do not have your program director be a voting member on the CCC. Why is that? Because we just said the CCC is the one who should be providing unbiased information to your program director, so they are not the last man standing. This should not just be kind of a unilateral, hey, I'm just going to make these decisions. Ultimately, yeah, you're right, it is the program director's decision, but they should be taking information from the CCC to make educated, deliberate decisions about that trainee based on what the CCC is recommending. The other piece that I'll go into is how do you divide up your CCC? So there's a couple different ways to think about this. if you look at the way it's described with ACGME, you can either do it for small programs, medium programs, or large programs. Small programs are programs that are less than 15. Moderate programs are 15 to 75. Greater than 75 is considered a large program. We don't have any of them. We don't have any large programs. All of our programs pretty much fall into this moderate bucket. So different ways to slice and dice your CCC. So you can say, hey, this component, I have 8 people on my CCC. 3 of those people are going to be evaluating the PGY1s. 3 of those people are going to be evaluating the PGY2s, and then 2 of those people are going to be evaluating the PGY3s. You can divide it like that. You can also divide it based on cohort. So you can say, hey, you're going to follow this class from PGY1 to PGY5. They're going to be here for 5 years, and we want to make sure that we have consistency in the course of this residence education. You cannot have a definitive way, but you can definitely slice your CCC to be like, hey, every single component or every single slice of the CCC is going to be evaluating 6 residents. If you were a smaller program, you can say you're evaluating all of them. If you've got a residency of Dr. Hamilton, you've got a residency of 5, you can have every member on that CCC evaluate every single trainee because it's easier because you have 5. What I would tell you to do then is I would take all that information, have it fed to your program coordinator, and then have the program coordinator create a dashboard on, hey, this is what we're going to vote on. There's something interesting that some of the larger programs do, probably say moderate to large, is they have, I have not seen this, and I don't know if you guys can raise your hand, they have the residents fill out their own milestones. And then the faculty will review their milestones and make a collective decision about what the insight is of that trainee of their performance. And so the same information for what the CCC gets comes to the faculty and goes to the trainee. Hey, trainee, sit here and look, and you tell us what you think your milestones should be. And then they just input that data, and the CCC comes behind them and says yes or no. I think it's a little dangerous, but I'm sure it probably works if there's really good guardrails as far as, hey, this is going to be acceptable, this is not going to be acceptable, but I can see a little bit of friction happening between the CCC and the trainee. But there are different ways, again, for those programs that are sitting at about 40 residents, it's tough. And so you have to figure out how to make it even and equitable, and then how do you present that information. It is really, I think, a good idea to have a chair of the clinical competency committee. Number one, again, I already said, probably the program director should not be the chair, the program director should not be the voting member. But then what does the chair do for you? I think the chair should really govern how that CCC runs. I think that they should look to see what type of faculty development do we need for the CCC to make sure they're all doing what they should be doing, and we're all operating under this shared mental model. It is very similar for the program directors that were in the room today, very similar about what we did today. I want us all operating kind of under the same understanding. Here are the expectations, here's what you say, here's how we do areas for improvement. You should consider having a chair of your CCC that really helps guide it. That chair of the CCC should 100% be the expert in the milestones for the residency training program. So we're going to talk about some tools on how to make individuals be expert on the milestones, but it is very important. It can be very, very valuable. You also want that chair to be pretty good about keeping people on task so that you can move things forward. You also want to make sure that the coordinator, the program coordinator, and the chair of the clinical competency committee are working in congruence, because we want to figure out what data do we really need to give these faculty to make a good decision about if this resident should be progressed, if they should be put on an ILP, if they should be whatever decision it is that you make. So that chair can work with your program coordinator to create those files so it's very easy for the rest of the clinical competency committee to do their job. So clinical competency committee function. Overall function, these are just straight out of the ACGB program requirements. You want them to review all the residents semi-annually, so that's really important. You can't get by with not reviewing your residents semi-annually. You want to prepare and ensure the reporting of the milestone evaluations of each, that should say residents, semi-annually to ACGME, and you want to advise the program director on resident progress, including promotion, remediation, and dismissal. Those are the 3 big things that come out of the CCC, 3 big decisions that you need to make. So frequency, I'll tell you frequency, we just kind of talked about it. We need to meet semi-annually by the letter of the law. I have encouraged a lot of programs in here about having their CCC meet periodically when a problem comes up with a certain resident. Like, hey, you need to call your CCC together. You need to call them together every single month because we're talking about dismissing this resident. There's nothing that says the CCC cannot meet more frequently than twice a year, but everyone's kind of like, well, it says twice a year, so what are you gonna do twice a year? If you have a problem with your resident, you need to pull them back. Remember, they are serving as your academic standards committee. So if you're having a problem with the training, to keep us out of the boardroom, have your CCC meeting more frequently and documenting what it is that they're finding with that training. So ways to maximize your clinical competency committee, this is probably where we probably should spend most of the time before the meeting. What do I need to do before the meeting? You want guidelines on how to prepare the resident fellow assessments. That's going to be determined based on how you want to divide up your clinical competency committee. If you wanted to divide it up between each by cohort, if you want to divide it up by longitudinally, do you want to divide it up by the number of residents that you have to review? How do you want your faculty to enter the data before the meeting starts? So I will tell you, being a previous program director, what was easiest for me was having those faculty actually input that data and the milestones. So when it comes to actually presenting the material, you're looking through a data sheet that's already completed instead of a data sheet that you're having to click through and just be like, okay, yeah, I think there were 2, okay, I think there were 2.5. Instead of doing it that way, have that data already incorporated, because then it's like a discussion about, do we all agree that this resident meets here? To be changed, absolutely, but at least you're starting somewhere and it's not taking as much time. How do you expect your faculty to present the data? Well, usually if you're dividing up the residency class, it's like, hey, these are going to be your 6 to 8 residents that you're going to be presenting. Here's a sheet on what I expect you to present. Like, does the resident need to be promoted? Do they need an ILP? Do they need to be dismissed? Do they need to be suspended? Make it very, very clear about what you expect that faculty member to be presenting on, and then let the discussion ensue. You have someone that you can put findings into your dashboard. Usually this is where I would really work very closely with your program coordinator to develop a dashboard that's easy to read and easy to navigate, easy to move through. And then again, I brought this up because I thought it was really interesting. Have you thought about having your residents complete their own milestones? Well, that is one way to do it. Just be prepared to deal with the consequences if it's completely off base, because some residents don't really have good insight. I will tell you that maybe it's a really good way to kind of weed out those residents that don't have good insight and realize the ones that are going to be a problem right off the get-go. The other thing that I want to say is place an importance on narrative data collected from the assessment. So we all do these end of rotation evaluations. I would say 95% of the time we kind of just flick down 3s or 4s or 5s based on where they are or where they think we're performing. Not having comments on those evaluations, I mean, it kills program directors all the time, because they're just like, you want me to dismiss this resident? You just gave them 5s across the board. That's a problem. And it happens, I cannot tell you how many times every single resident that has been dismissed in my very short tenure, in like less than 12 months, I have gone back to the program directors and I said, there's absolutely no way that I'm going to stand by this decision, because you don't have the documentation. There's no comments on your evaluations. There's no timeline that I can read. And to quote Dr. Beeman, we're gonna end up on CNN or we're gonna end up in the courtroom. Because I can't prove by any stretch of the imagination that this resident or this fellow was ready to be dismissed. I know there are program directors in here that are rolling their eyes at me because they didn't go through it. But it is so important, and this is why it's very important that the chair of your clinical competency committee figures out how to do faculty development for your faculty and for the CCC.
Rapid response, intern lobby. Rapid response, intern lobby. Rapid response, intern lobby.
During the meeting. So how do we manage ourselves during the meeting? I'm not going to belabor the shared method model. Everybody needs to walk into that meeting with the same understanding of how we're going to evaluate this resident. Walking into the meeting under the same understanding that we're going to make decisions about promotion, dismissal, renewal, or ILP. And that's what I say when I say have a common understanding of what is expected. I'm going to talk to you about, and it's really terrible to read it, I'm sorry about that. Consider using, if available, positive predictive value. I'll show you a slide about that shortly. Assure there are multi-modality means of assessment. And so what do I mean about that? Like, I've already kind of mentioned that. All we do is these end of rotation evaluations. I mean, I can tell you 85% of how we make a milestone assessment on these residents is the end of rotation assessment. We're not using EPAs. The reason I've been kind of on Martha about getting this DOCC up is because there's no formative assessment in the way we're evaluating these residents. There's nothing that's in time. I know that the emergency medicine training programs, they do a lot of things like shift cards, which are great because it's formative, it's in real time. But we don't have something necessarily for everybody. So we're trying to find things that will encourage people to actually use formative assessment. 360 evaluations. Are you having nurses evaluate your patient? Are you having social workers evaluate your patient or patient resident? Are you having peers evaluate each other? Are you having your program coordinator evaluate them? I will tell you, 85% of the time, your program coordinators know when there's a problem with the resident before any of the faculty and before any of the program directors, because they're dealing with them. Hey, they won't finish their duty hours. I've called them like 400 times. That's a professional submission. Hey, they didn't get their license done on time. Hey, they didn't do this. Hey, I'm having to do this for them. I would strongly consider sending those 360 evaluations to your program coordinators. They know when there's a problem with the resident. They usually know before they start because they can't get their paperwork on time. And so having that information available to you is huge. Again, they can't vote on the CCC, but they can certainly be an integral part of your CCC. The other thing I want to emphasize is don't come into the CCC with a predetermined verdict. It's not the purpose of the CCC. We can all be thinking it, right? We can all be thinking like, man, we're going to skewer this resident. You might be wrong. You might absolutely be wrong. You might have no idea what's going on in the background with that resident. You may have no idea that their sister died, and they've been struggling. Like the things that you will find in the CCC, I just ask everybody to have a little bit of latitude and laxity. These kids are working 80 hours a week. They're seeing things they've never seen before. They came out of this COVID generation, which sat in a classroom for like a million years. There are a lot of things that you probably don't know that are going on with the residents, and just having a little bit of latitude. The other thing, I keep emphasizing, hey, the program director should be a voting member. I should probably clarify. I don't think the program director should not be on the committee. I just don't think that they should be a voting member. And why do I think that they should potentially be there is because sometimes they have information. Now, they should not start the conversation, but sometimes they have information in the background, kind of like we said, oh, hey, do you know their sister died, or do you know X, Y, and Z? Sometimes they bring that information to light, and that's important. The other piece that I didn't bring to is I've been asked like, hey, can the mentors participate in the CCC? I mean, they can. Feels like a conflict of interest because, their whole thing is like, be the cheerleader for the resident. It's not about cheerleading. And so I'd be careful about inviting advisors or mentors to your CCC. So how do we make decisions during the meeting? They're usually based on consensus. ACGME absolutely offers zero information on how CCC should make decisions, zero. And so I suggest to the program, like, you really should try to come to a consensus. Now, is it always going to be a consensus? Probably not. You should get as close as you possibly can. The last part, and I've heard this before too, the recommendations from the CCC are recommendations. There is nothing in the ACGME requirement that says that the program director has to uphold the recommendations from the CCC. I have yet to find a stark difference between the CCC and the program director. It's really important, I would say, that having a really good chair of the CCC that has a really good relationship with the program director so they can have frank discussion. Because if the program director, just remember, how are you going to explain this when you're sitting up in a courtroom that your CCC unanimously said that the resident had a problem with X, Y, and Z and the program director overturned that? It's important that you want to make sure that there's some cohesion between the program director and the CCC. So I alluded to this before. This is, actually, I don't think I alluded to it. Before you go into the CCC, this is a document that's created by ACGME. And in this document, you can see they've got the milestone up top, patient care history warrant. they have information about how the resident should be performing per specialty on every single one of the milestones for the subcompetencies. So if you Google subspecialty data, ACGME, so internal medicine subspecialty content, they're gonna come up with a document that looks like this. So they're gonna tell you exactly, and you don't have to think about it. You can give this to your CCC, just be like, hey, this is what tells us if the resident is really performing at this level. So if at a level 1 for patient care, can they do those things? At a level 2, can they do those things? Level 3, can they do those things? This becomes an invaluable tool for deciding if residents are really performing at the level that they should be. Frankly, we should probably be giving this to all of the faculty that are consistently evaluating residents. But they've already done this work for you. You don't have to figure out what they should be doing at level 1, 2, 3, 4, and 5. Somebody already figured this out for you. So this is something that's very, very helpful. And when I say, hey, your chair of your CCC should be the milestones expert, guess what? They don't have much work to do. They just have to know this document. And they have to know it well. The other thing, and I don't know how many of you guys have seen this, the positive predictive value. Has anybody seen this? So this was super interesting to me. So this is also something that was developed to determine if a resident performing at a specific level will reach a level 4, which is really autonomous practice, not exceptional, but autonomous practice, by the time they graduate. And so you can see they've marked year 2 and 2. So if you follow that arrow down, if they are scoring below a level 2.5 on their milestones, they have a 54.7% probability of not reaching a level 4 by the time they graduate. And so again, when we're thinking, we're just like, hey, is this resident gonna make it? Is it not gonna make it? Well, again, somebody did the math for you. Somebody did the science for you. This is an ACGME approved document, and they'll tell you if your milestones are done correctly. So Dr. Duncan had mentioned, hey, by the way, in your evaluations, everybody has this nice neat circle when they're a PGY X. Well, this document's not really helpful for you then, because nobody's actually adequately evaluated the trainee. But if they are at this level, ACGME says, and this is for program, for specialty specific. So you can find this data specialty specific for you, internal medicine, radiology, emergency medicine. You can find this data very, very helpful to really make an educated decision, a sound scientific decision if that resident's going to progress. So after the meeting, what things can we do? You want clear processes for CCC recommendations to the program director. I don't care how you do it. That should be really developed by your chair. Like, what information am I going to be supplying to my program director? First thing that you want to make sure is the resident progressing. Do they need to be remediated? Do they need to be dismissed? If you're going to make these decisions very similar to what we did this afternoon, you have to have reasons why. So if you're making a decision that the resident needs to be put on an ILP, you need to be saying why. Your job as a CCC is not to make the ILP. Your job is to make recommendations that an ILP should be considered or dismissal should be considered for X, Y, and Z. You should also help your program director by giving very kind of grand generalizations about expectations for follow-up. Most CCCs say, hey, this resident's in trouble. We probably need to get back together in 3 months, and you need to communicate that back to your program director. Feedback for non-struggling residents, we've kind of already talked about that. Everybody needs feedback. And then also, the CCC kind of serves as a little bit of a linchpin. They can really help kind of be that glue that serves as moving the residency training program forward in identifying weaknesses of the program, resources the program needs, generalizations of where the residents are struggling. Like, so I kind of made the mention earlier, like, hey, they're all struggling in endocrine. We can see that based on X, Y, and Z. Maybe this is an opportunity for the CCC to say, look, we have a problem. We need to focus on this. So how do I get there? Feedback from the CCC, really important that you're timely. If your CCC meets, it does not need to be a 90-day turnaround time for the program director to get information. They're about to launch into their semi-annual meetings. I understand that it's hard on the CCC to make this data cohesive, but then your program director needs to figure out how to deliver this information. So timeliness is key. Specificity. Don't use things like, hey, the resident needs to do better. That is so not helpful for the program director, and it is so not helpful for the trainee. I mean, we might have all said it, doesn't go anywhere anymore. You need very specifics and you need examples to support why you're saying what you're saying. If you're saying this resident is unprofessional, don't leave it at that. What are the examples of the resident being unprofessional? You can't put these grand generalizations out there and just be like, hey, good luck, program director, figure it out. CCC can also, like I already mentioned, recommend the development of ILP by the training based on their feedback that can be shared with the CCC in the future. So very briefly, let's talk about the ILP. The biggest thing I'm going to say about the ILP is it should be generated by the trainee. By the trainee for the trainee, with support from whoever it is that's assigned. It could be a mentor, it could be the program director, it could be somebody from the CCC, but the CCC's responsibility, the program director's responsibility is not to generate the ILP. You can provide forms, you can provide guidance, but you should say, hey, you've got an issue with your performance on your IT exam. How are you going to improve that? They should be able to give you some feedback on how. They know themselves better than you do. Like, I'm not a visual learner, I'm a this learner, I'm a that learner, so they should be able to give you ideas, and then you can have a facilitator of that ILP help make that more cohesive, identify areas that are completely missing, but that information should be fed back to the CCC. This is kind of closing that. Components of an ILP, reflection on their goals, again, remember, for the resident, by the resident. Self-assessments on strengths and weaknesses, specific plans or strategies on how they plan on achieving their goals. So if their goal or your goal with them is I want their IT to go up by 25%, how are you going to get there? Where are you going to set in place? How progress is going to be measured, and timelines. And this I find oftentimes missing when we're putting somebody on a non-reviewable concern or reviewable concern. What's the timeline? When is my end date for when I'm going to evaluate this? Like I said that you need to show improvement in professionalism, and I'm going to check back in with you in 90 days. What am I doing when I'm checking back in with you? Hey, are you being professional? Yeah, I'm being professional. Okay, it's cool. No, there needs to be very specific benchmarks on what you are measuring. You need to be able to prove how you measured it. You need to prove how you made an intervention, and you need to prove how you're actually going to measure it at the outcome. Previous known as the final summit evaluation. That says final evaluation on the left. It is not, again, created by the CCC. Everybody should have a final evaluation for each one of their residents that graduate. In that document, and everybody's is a little bit different, I've seen like a handful of them, it's pretty much saying that the resident is autonomous to practice whatever their specialty is. Some of them have specialty specific case logs. Did they meet their case logs? Some just have specialty specific milestones. Again, use that cheat sheet that ACGB provided for us. But you want to be able to say that that resident is autonomous to enter into practice. Can also be used as assistance for residents who are dismissed or resigned early. It becomes essentially a document that's retained for the trainee's completion or lack thereof within the program. What do you do with that? Do you send it to the board? Do you send it here? No, you don't send it anywhere. It stays internally on the file so that when someone comes back and they ask kind of what happened with the trainee, we have something on file that is a written record. Or if it was anywhere else, we know exactly what happened in the final evaluation that helped us make that decision. If it is for residents who are dismissed or resigned early, you see kind of those 4 sub-points there: date of enrollment, prior education, description of behavioral and academic concerns, and summary paragraph of the PD's overall impression. But that should stay on file, and that should be approved, vetted, discussed with the clinical competency committee. So legal issues, I would probably say this is the biggest legal issue: academic due process. Was the resident appropriately notified when they had deficiency? Did you notify them the day before you dismissed from the training program? Because that's a problem unless it was never a event. I find that we let residents go almost all the way to graduation, and then like 3 months before graduation, we're like, wow, you have a problem, you shouldn't graduate. So notice of deficiencies, was it an ample time? Opportunity to cure. We're also missing that part half the time. What opportunities did you do or enact to help them get better? Can you prove it? Can you say, I put them on this ILP, they created it, We had these benchmarks with them. We saw them every single month. The CCC met about them every single month. They didn't meet it 50% of the time, or they got worse in these areas. And careful and deliberate decision-making processes, which is why I say there should be a narrative that's associated with each trainee. Confidential narrative that stays with the CCC and the program director, but there should be a narrative as to why the CCC made decisions, particularly in areas where we're going to be very concerned that the resident actually got due process. Each institution should review its peer review statute with its legal counsel to determine if it can be applied to the CCC. I've talked to Amy a little bit about this, and Amy's here. She's a legal counsel for CHS and AMICO, or for the sponsoring institutions, if you will, about what can be shared, what cannot be shared. And I've talked about this previously, like, do not share this information voluntarily with anybody, ever. If you are requested to share this information, if it comes from subpoena, completely different. If you have a resident that's been dismissed from the training program, before you share any information, it should be discussed with your legal counsel. The other thing is we've created a form that Molly has on SharePoint, which is called an authorization of release. If that resident has been dismissed, you can pull down that authorization of release and we can fill it out and we can walk through it together. The residents that are dismissed from the program or do not satisfactorily complete the training program are the ones that you have to worry about. The CCC's input and narrative can be extremely helpful in making sure that we stay covered on all legal grounds. And then we put at the very bottom, the carefully conducted CCC is one of the strongest legal defenses to support dismissal actions. Unwritten uses of the Clinical Competency Committee can be used for assessing and transferring residents and fellows. So residents are coming in, we can use the CCC, hey, will you review X, Y, and Z to see if this resident is going to be performing where they need to be, what part of their training should they come in, they were surgery resident, they wanted family medicine, maybe they're going to get 6 months of advanced credit, use your CCC for this. Assessing the evaluation model of the program, we're going to talk a little bit about more of that in detail. Contributing to the annual program evaluation, like I said, the CCC and the PEC should be working in tandem. Faculty development, we've talked about quality improvement and assisting the GMEC when there are issues with problematic residents. And so I just wanted to talk about assessing the evaluation model of the program real quick. This would be much better if I had a whiteboard so I can explain what this is. But if you Google, it's like the American Pulmonary Critical Care, something like APCCD something. They have this really good 8-step format on how to determine if your evaluations are hitting the milestones. And this is just kind of snapshot out of it. I would focus on this bottom left. And so what they tell you to do is they tell you to look, you start looking at the milestones of your program. And so the milestones of your program, patient care 1, 2, 3, 4, whatever it is in that specialty document that ACGB provides. You have that on your left column. And then you say, are we evaluating it? Is there evaluation form? Is there an evaluation anything that measures PC1, PC2, PC3, PC4, medical knowledge, 1, 2, systems-based practice? Is there something that exists in your program that actually truly assesses that? The answer is yes, super, move on. The answer is no, you probably should look at it. With that, then you go to rotations. So you can see the rotations are kind of in the screen. This is like the first year. And so over here, you can't see it because it's cut off, but it's like PC1. So PC1, you see this 1, and that says, okay, my end of rotation evaluation actually measures patient care 1, and that's history and physical examination. Same thing, end of rotation looks at it on the VA, Veterans Association consult service, whatever group this was, it's measured in all of these areas. When you find that it's not matched up, or you can't find a place on how you evaluate it, it's going to show you holes and where you're missing your evaluation form. It's also going to show you that like there's some things that you really can't evaluate with an end of rotation evaluation, right? Like you can't evaluate how they did journal club with an end of rotation evaluation. You can't evaluate necessarily how they did certain procedures with end of rotation evaluation. Maybe some, but not all. It becomes a really important tool to make sure your evaluations are doing what they're supposed to be doing and do they need to be redone. The other thing that ACGB is making a really big deal out of is they don't want one evaluation tool to measure how the residents do. They say they want at least 3 different ways that the resident is being evaluated on every single milestone. That's a lot. I would say let's go with 2. Something in the middle. But I would say that you do not want to rely solely on your end of rotation evaluations to determine if a resident should progress or not. You have to come up with something different. Formative evaluation, summative evaluation. EPAs. You can look at 360s. Like there has to be different ways that you're evaluating the resident, and you can use, and I can send the link out because it gives you this nice, clean 8-step process and how to determine if your evaluations are doing what your evaluations are needed to do. This is going to be the last slide. This looks at just mapping evaluations too. What are your options? Like, so for IM milestone PC1, they gather and synthesize essential and accurate information to define each patient's clinical problems. You looked at that by the end of rotation evaluation, by the clinical rotation, by an OSCE, like we sent them down to the sim lab to actually do an OSCE, use the mini CX, which I'm kind of trying to hope to move to the DOCC, and then this. These are the 6 different ways we're evaluating this specific milestone, as opposed to the one on the right, where it's like, yeah, we're just looking at the ICU evaluation by the faculty. That's going to be a problem when someone comes in and looks at this. We are having Laura Edgar. She works for ACGME. She's kind of their milestone expert. She's going to be coming in November to kind of give a little bit of faculty development on how to use the milestones and how not to use the milestones. But we figured that this was a pretty good place to start. So take homes for me, essentially, clinical competency should be very, very involved in assessing your residents. They should be providing information to the program director. They should be providing information to the program evaluation committee, potentially providing information to other groups that are stakeholders in your residency training program. Their information should be complete, it should be concise, it should be confidential, and it should have narratives for any resident that is in trouble. You should be able to go back to the document to justify why the resident was without remediation, what were the opportunities of the cure, and what was the timeline that was set forward. Your CCC is not confined to be twice a year. Your CCC should be called back together anytime there are issues with your training program, so that you can make sure that you have a timeline and you have a written record about what you did to remediate that training. ILP should not be developed by your CCC. It should not be developed by your program director. It should be developed by the resident for the resident with facilitation. Questions for me? Yes.
So with regards to the idea of having the residents create their own ILP, I've had residents in the past who had 0 insight. You could pick them an example of something they did that was less than desirable. And they would say, I don't really see anything wrong with my behavior in that situation. So how do you take somebody like that who has 0 insight, thinks they're not doing anything wrong, and create an ILP about profession?
Yeah. Tricky situation. I would say with those particular residents, it's number one, maybe they need to go to the professionals committee. Let's start there. Number 2, when I'm usually talking to a resident, and I mean, I know I've talked to a couple of your residents, I sit there and I continue to ask them questions until they can finally come to the answer like, oh, maybe I shouldn't have done that. And you've got to use, you've got to use examples, and we do this a lot when we do proof of conversations. Use examples, take it out of medicine, and just be like, hey, if I called so-and-so this name, my neighbor, how do you think that's going to go across? And then all of a sudden they're just like, well, that's terrible. Why would I ever do that? Yeah, well, why would you do that with a patient? And all of a sudden you can kind of get them back to where they need to be. Sometimes you can't get them where they need to be. And I understand that. Sometimes then it becomes the responsibility of the program in and of itself to really, and that's why I said the ILP is for the resident, by the resident. It needs to be facilitated by a faculty member. And sometimes that facilitation is more rather than less. Sometimes you'll find that residents actually pour more into their ILP than the program faculty actually put in. And so if you get to a situation, you can always call the professionalism committee or whomever to talk about, hey, can you give me some tips and tricks on how you would do this? Call me. And we can figure out how to create an ILP that meets them, but then they're gonna have to commit to that. You're gonna have to bring them back in and they're gonna have to commit to it. And we're all gonna have to sign off on the same piece of paper that says we understand what the expectations, the interventions, and the timeline are. Other questions?
On the examples you gave for the milestones.
The 8 steps. Oh, no, the subspecialty, I will send it to you. It's subspecialty specific, and so everyone has it, so we Google it and you can find it, but I'll get that link out to everybody, just an example for that, the predictive values, and then the stuff that the APCCC and D created. Because I think that there's gonna come a time when we really have to look at our evaluations. I do not think our evaluations are doing what they're supposed to be doing. They are not linked to the milestones, they're not linked to the sub-competencies.
There's no comment, there's no comment.
Right, but that's why,
Coaching to the people that are throwing out the evaluation.
right,
That's an example.
no, you're absolutely right, and that's why the chair of your, I think that's why the chair of your CCC needs to become kind of an expert in that area. And it's also why ACGME is telling everybody that they're gonna stop accepting end of rotation evaluations as the sole mechanism of assessing a resident. Because it's not giving the program directors what they need. And it's honestly not giving the residents what they need either. Other questions? Yes. That's correct. That's correct.
And then I think.
That's correct. And so the pediatrics group has been very big in the ILP world, because they think every resident at every single point should have an ILP. And this is kind of when I said the CCC should be providing feedback on every trainee. They should be. Not every resident is ready for autonomous practice, certainly not when they're a PGY1. So even those stars need feedback, okay that you're doing an ILP for every single resident, but ILP might be, because the other thing they're big on, ILP is not a portfolio. It is an individualized learning plan. Not a portfolio, not the document that you're gonna submit back. It's a plan for that training. Other questions?